good afternoon, everybody. Welcome to the Wales Value Healthcast. I'm Dee Lowry. I'm Head of Value-Based Healthcare at Cwmtaf Morgannwg University Health Board. And welcome to our Value Healthcast this month. This is on acute care. I will be having two guests with us. Unfortunately, Nick and David can't join us today, so I'm flying solo. But I know that our two guests are going to be really interesting and that you're going to hopefully have some great questions. So today we will be joined by Claire Dunstan, Dr. Claire Dunstan from Cardiff and Vale, who is the Cardiff and Vale University Health Board clinical lead for Value. She's also the assistant director for the surgical clinical board and a consultant anaesthetist. And we will also be joined, as you can see on the screen here, by Drazen Vuti. Drazen is a consultant oral and maxillofacial head and neck surgeon who has been working on the sentinel lymph node biopsy for oral cancer, also at Cardiff and Vale. So Drazen, if you'd like to just start with a bit about yourself, a bit about your background. I've heard that this project is something that you've really been championing since you've joined Cardiff and Vale. So if I just hand over to you for a little minute and you can tell us what you've been up to.
Thank you so much. Thank you for inviting me to the show, first of all. And yeah, thank you for giving us the chance to explain that to you, what this is about with Claire. And yes, indeed. So I'm originally from Hungary, but I trained in Scotland. And also I did a fellowship in Birmingham. And following the fellowship in Birmingham, I got appointed here as a head and neck maxillofacial consultant. So my subspecialty interest is oral cancer. And oral cancer involves a lot of treatments, and some of the treatments are traditional ones, some of the treatments are like newer ones. So the sentinel lymph node biopsy, which is my other interest, is part of the new oral cancer treatments. This is a technique, and I'm going to explain that to you a little bit in a historical context, which been introduced into breast surgery. Not many people know probably that originally the first sentinel lymph node biopsy was done for a parotid, a head and neck cancer, but breast surgery adopted it very, very quickly. Following the breast surgical application, a lot of other specialties pick this up, including gynecology, oncology, dermatological oncology service. And lately it's been picked up in oral cancer. And just to put that again in a historical context, what I'm dealing with mainly is oral cancer, which got two types of features which are really important. One is that it grows and eats all the tissues around it. The other one is that it can spread into all sorts of lymph glands into the neck. And historically, this been treated always with surgery, and the mainstay of the oral cancer treatment was always surgery. And it entailed two bits: to take out the cancer and to deal somehow with the lymph node spreadings. But the dealing was interesting, because what we do, even if we don't have any lymph node spreadings on an imaging, we know that sometimes in 20% of the cases, what we see on the imaging is not really true in real life, because in real life they pop up lymph node spreadings. And how they dealt with in the past and so far as well is that they did a so-called neck dissection, which is a 2.5-hour operation where we basically take out either one side of two sides of the neck. And that include, when I say take out, we take out all the glands, including fatty tissue, some salivary gland, and all the lymph nodes as well. And we probably remove on one side 30-40 lymph nodes on a person. From these 30-40 lymph nodes, not all of them are cancerous, but we don't know which ones are cancerous and which ones are not. This is quite a big procedure, and it comes with all sorts of risks, like every surgical procedure. So we can cause some nerve damage here in the neck, which is not very good, because there's a lot of clockwork in the neck. So everything does something. So if you damage something, that obviously has consequences. But at the same time, in the past, from the data, we know that, like in early stage cancers, we did all of these neck dissections, and 80% of the patients didn't have any cancer spreadings. So we did basically this procedure for nothing. And that is really important to understand. We just couldn't predict which patients are those which have spreadings as opposed to those which don't have spreadings. So we adopted this easier procedure, which comes with less morbidity and a much smaller surgical time, called the sentinel lymph node biopsy. And I explain here what we are doing. So as opposed to taking out all the glands and checking all the glands under the microscope, we just take targeted lymph nodes out. And that is really important. So what we do is we check which are those lymph nodes which are related to the cancer site, and that comes with a special imaging, which is available in the health board. Everywhere is available. This is not something which is not available. In most of the hospitals which are dealing with breast cancer, this is available. And it's part of the nuclear medicine procedures. So we check which are the glands, which are the lymph nodes, which are related to the cancer site, and we only take those out which are related to the cancer site. The way it works, we need to do a special radioactive dye. So we use a radioactive dye, which we inject around the cancer, and we see where it spreads. And when we discover the nodes, following the injection, we go and perform a surgical procedure. When we make small cuts on the neck and we take out 1, 2, 3, 4 nodes, up to 4 nodes. So like the 4 highest counting nodes, as we used to say. And when I say counting nodes, that means that they give the highest radioactive counts. So you can guess that, like, based on what I just said, that like we take 30, 40 nodes, or we take 3 or 4 nodes out, that is a significant difference between these two procedures. And the difference comes in surgical time, surgical load, and also the morbidity. So obviously the risks and the complications which come after a neck dissection, and also the operative load which comes with a neck dissection, is much bigger as opposed to the sentinel lymph node biopsy. And just to enlighten you, this is a technique which I learned in Glasgow, and we audited and also did an article and research in that. And just to compare these two techniques, so when we do a neck dissection, patients are staying in 7 days in a hospital. When we do a sentinel lymph node biopsy, patients are staying in 1 or 2 days in the hospital. And obviously, they don't need to go to the intensive care unit. They don't have the same complication profile. They got much less, and they all happy with it. And this can indicate that which nodes got cancer in them or not. Obviously, what we call the sensitivity or the specificity is not perfect, but none of the staging procedures got this perfect specificity and sensitivity. And whether this is something which is comparable to neck dissection, that is something which is investigated now in oral cancer treatment, because there is some evidence that it is comparable and it is perfectly fine. But the big study is going to come out now because the big trials are going on at the moment.
Fantastic. So there's significant difference in the amount of surgery that's taken place. And you said that the patients, it's much better for their recovery time. So there's a lot of saving in theatre time, in medications and complications as well.
Exactly. And this is the most important bit. And this is why this was a good value-based project, because value-based medicine is not just based on evidence, it's based on what is important for the patients. And this is something which is like crucial in this project. And Claire Dunstan kindly facilitated this project as well. So like she played a major role in getting this project all over the fence.
Oh, fantastic. So how many patients have you actually seen through the project that you've been doing now?
So we started the project in January, and we did already 6 patients. And all of them, apart from one, we obviously auditing the data, and the first 6 months of interim publications going to come out recently, or going to come out currently. But we audited the data, and all of the patients are showing what we expected them to show, that they go home the next day or the day after, as opposed to 7 days, and they are quite happy with the outcome. And also, we had also done I don't want to. We had also colleagues who, oh yeah, I don't want to get into patient-sensitive data, but we had also colleagues who were in the NHS, and then they received of previous colleagues who were in the NHS, and then they received the procedures, and they knew what a neck dissection is about, and yeah, they were surprised as well compared to that how small this is and how better this is.
So what are the other impacts on the patient outcomes? You said previously, obviously, it was quite a significant amount of surgery, and patients are well enough to go back in shortened time. But are there other patient-focused outcomes that they're finding as well because they're having less surgery?
Obviously, since we are talking about cancer surgery, it's a survival which is the most important here. And yeah, so the survival data is comparable, but obviously it's early days to say that because the survival is not going to come after 5 months or 6 months. It's going to come following 5 years. So the answer to your question is whether it's comparable. Here in South Wales, we don't know that yet, but I know from Glasgow, from 150 patients, that it is comparable. So if we can transfer this service to South Wales, that would work perfectly.
And are you looking at the scalability of, are you discussing this with your colleagues across Wales?
So yes, so since we started this here, we want to go through the first 10 cases as let's say the pilot cases, and after that we would try to expand that to whole South Wales, because this procedure is only done in North Wales. And this is the first center who does in South Wales, this one. So it is scalable to the whole South Wales, to the other health boards as well. And I'm pretty sure if we gonna sit down on a managerial level to discuss this, it's going to be quite appealing that like patients are staying less time in the hospital, we sparing beds. Like we projected probably 40 days of hospital in stay sparing on 10 cases for a year, which is quite a big one. If we look at it, that on 10 patients, we can have 40 days inpatient beds in a hospital.
Yep, and surgical and theatre times, is that decreased? You previously said it was a 2.5 hour procedure. What sort of time are we talking about with the Sentinel approach?
So the Sentinel, we're talking about probably half an hour to 45 minutes, maximum an hour. So we got 90 minutes in the theatre, what we spare on a sentinel lymph node biopsy. That means that, for example, we can't do an excision of a tumor and a selective neck dissection on one sessional list. This is easily doable, plus you can put another case on.
Fantastic. And you mentioned that the scanners and the materials in order to do this should be in all the hospitals anyway. So what do you think will, if there is one, will be the biggest challenge to scaling up? Do you think it should be easy for others to pick this up or not?
I mean, yeah, so they can't do the scanning because this is, I didn't tell you that, but this got a quite strict timeline, this procedure. So when we inject them with the radioactive material or the special dye, that decays in 36 hours completely. So it needs to happen one after another. So we need to inject them, and within 24 hours, we need to do the procedure. So probably the logistics going to be the most difficult bit, to find the ways to get them here, and get it sorted at the right time, and then get the list sorted at the right time. And that's why this project was a little bit more difficult than the other ones, because we didn't just introduce something which we could do anywhere. This is something which is very specific to a theater, because the theater needs to get trained, the nurses needs to get trained, the ward needs to get trained, and the staff who is operating needs to get trained. So it is very specific for a certain place, for a certain place, and that place can only be in a certain time after the injection. So the logistics is going to be the most difficult bit.
Okay, so you mentioned about the radioactive iodine then, and then the 36 hours. So is that done in like an outpatient session, and then the person goes home and comes back in?
So what we tend to do here it is possible what you just described. It's not iodine, it's a radioactive technetium.
Sorry.
It's a 99 metastable technetium, but it doesn't matter. So when we inject them, they could go home,
Okay.
but we tend to keep them in because what we do have is this 2-day protocol where we inject in the afternoon and next morning we start with them immediately first thing to be able to detect these nodes with a special gamma counter in the theater as well. That is something which we adopted here. I took it from Glasgow, but in theory, it would be possible to inject somewhere the patients get the study done, and then they go home and they come back next day.
Okay. It's just interesting looking at that flow issue, isn't it? As you say, it's very time constrained to make sure that you're able to build on the one part into the next part. So how many patients in Wales do you think that this approach could actually be used for? What's the cohort at the moment?
It's suitable. Probably we do just above 10 cases, 10, 15 cases a year. We projected somewhere around 20, but I don't think we're going to have 20, especially not in first year, but probably 10, between 10 and 15. We are looking after population of 500,000-600,000. So like if we upscale that to the whole South Wales, that could be easily, I don't know, 50, 60 cases a year with all the health boards, but obviously they need to be all on the board.
Yeah, absolutely. And so you mentioned that work was going on at Betsy. Have you had any earlier discussions with the health boards? I know you're waiting until you get to your 10 cases, but are you finding people coming and talking to you already? Is there some interest in the field?
No, we don't. I didn't start that yet. Probably it would be a nice project. What I mentioned is I mentioned to my colleagues and obviously the colleagues from the other health board. And yeah, there is some interest to come over because this could be a joint procedure easily. So they keep the patients, they come over, they do take care of the cancer, and we do the sentinel lymph nodes on the neck together. So it is perfectly doable. It's just we need to get that ball rolling.
Yeah, absolutely. I think you might find that you have a few calls and a few emails following the post podcast going out. So we have had a question in from David Whaling at Cardiff and Vale. Do you have any stats on the positives that people can hear a little bit more about, or David's asked, are they a bit secret pre-publication?
So far, we got one positive case, and that probably reflects my statistics from Glasgow as well. So in Glasgow, we had 21% of the cases has positive lymph nodes. And here we had one lymph node already from the 6 cases. So we're somewhere around that. But I cannot tell you furthermore because, again, it's not published yet. But yeah, we got positives. Yeah.
So what's your publication timeline, Jazen? Because I think there's going to be a few people keeping an eye out for this now.
Oh, that is a good question. I don't know that. Yes, as soon as we collect it, we try to publish that. Yeah.
Yeah.
And again, this is just going to be the pilot. So like, yeah, the bigger study would be something when we collect a little bit more patients, and like that would probably take a decade till we're going to have a robust data on this, which is statistically significant. But we got other ideas as well here, so like that's.
So what are some of? So has this made you think about other ideas then that you know some other value approaches within your field and within the work that you're doing? Has it led you to think, oh, what else could we be doing?
Yes. So, not to be honest, it is related to this, but again, what happens is when we got a positive lymph node, we do a neck dissection to complete the procedure in order to see whether there are any other nodes as well. And this is something which everyone follows in South England, Midlands, and here in South Wales. But in Glasgow, where I came from, there was an interesting approach. So they tried to spare the completion neck dissection as well. So for those cases who had clear indication for radiotherapy, they went straight to radiotherapy from sentinel lymph node, which would be another value for the patients because they wouldn't go through a big surgical procedure again. even if they're positive, just they would go straight to radiotherapy. This would obviously need a robust data and a very big randomized control trial, which would be a multi-center trial, probably international, to gather all the numbers together. And that would be something which probably would be a job, probably would be a work for a life, so a decade or two.
Yeah, absolutely. So when you're ready to be having those discussions about scaling up, how are you going to be working with your colleagues? Is it that they can come down and shadow your team and get some get some peer training, or what are your thoughts around that?
So they can get trained as well, but if they're interested, but they can come down. Yeah, they can take out the cancer, because at the same time when we do the sentinel lymph node biopsies, we remove the cancer as well. So they can remove the cancer and we do the sentinel lymph node together. And if they want to learn, yeah, they're happy to get trained, that's fine. We can train them. So that's not something which we wouldn't like.
Fantastic. I think one of the key areas I always see with value-based healthcare is it's a very open sharing approach, isn't it? It's very much across clinical teams and across health board teams, very much taking that approach of what can we do and how can we improve that for the whole of the cohort, the people that need it. So I think there will be quite a few people that will be really interested in hearing more. So Jasmine, thank you very much for coming on today. Again, if anyone's got any questions for later on in the session, please do put them in the sidebar. I'm going to ask our technical team now to help me bring in and introduce Dr. Claire Dunstan, if you could. Jasmine, if you'd like to stay on for more questions, Jasmine's very kindly come in between procedures, so we do really thank you. Also recognise that if you do need to pop off, that is the agility that is our NHS. So thank you very much.
No, that's fine. I'm happy to stay.
Fantastic, thank you. And Claire, thank you for joining us today. Really pleased to have you. I hope you're doing well. So as I mentioned earlier, Dr. Claire Dunstan is the clinical lead for Cardiff and Vale for Value in secondary care. She's also the Assistant Director for the Surgical Clinical Board for Quality, Safety and Value-Based Healthcare, and she's also a consultant anaesthetist. So hello to you today, Claire.
Hi, good afternoon. How are you?
Not bad at all. I'm flying solo today, and I know there's been a few techie issues in the background, but thank you very much for joining us. So I know that you're very proactive in the value-based healthcare world at Cardiff and Vale, and Jason was speaking earlier about the support that you've given him with his project. Could you tell us a bit more about your role, and what does it involve from a value perspective in secondary care?
Okay, so I'm the acute care lead. So in Cardiff and Vale, there are two leads, one primary care lead, which is Richard Baxter, and also then there's the acute care lead, which is myself. So primarily what we've done is we have divided it up into projects that have been funded from the Welsh Value and Health Centre. And then I've taken more on board the supportive projects, as we call them. So that is linking between operations, finance and the clinicians. And I think that's where I'm sitting at the moment, is in between all three, and trying to make sure that everybody understands each other's position and so that everything gets moved forward. And I think if we use Drazen's project as an example, I think there is a need for somebody there to try and link in with everybody, ensure we're all pulling in the same direction, and make sure that these projects get over the line, because there's always other things that happen and it's never as clear cut as we'd all like it to be as clinicians. It's quite lumpy sometimes. And I think even with Drazen's project, which appeared to him as a clinician completely clear cut and why weren't we doing it, there are other things that we needed to consider. And I think the reason Drazen's got over the line really quickly was that he looked at his risks and he tried to mitigate them in a really early stage. So the project planning phase of any project, big or small, is really the most important bit of that. And so, yeah, I'd really applaud him, because he did work through some project planning, which to clinicians can be hard work.
Yeah, absolutely. And what are your drivers for value, Claire? Why this area of work? Why does it interest you?
I think probably it's born out of some frustrations of, you know, seeing opportunities of where the NHS could work more effectively, more efficiently. It's also born out of seeing things that I'd like to get done and trying to understand the area that I work in and how I can get that done. And if you look at medicine as a whole, we've moved from, you know, medical evidence, medical effectiveness, all the way through to actually, as clinicians, we now need to understand the financial implications, environmental implications, the social implications. We can't just say, actually, this is medically evidence-based. We don't have, you know, an unlimited pot of money. GDP isn't going up as much as we'd like healthcare costs to go up. So we've just got to be really mindful of that and bear that in mind and look at the whole picture and understand whether our new technique, whatever it is, or whether it's a piece of kit, is actually value. And it does sound a bit cliche, but if we look at it practically, it needs to provide value for money, value for the patients, and value for the NHS as a whole.
Yeah, absolutely. And what is Cardiff and Vale's kind of approach to this? You know, what is it a big driver in your health board?
I'd say yes. You know, I think everybody is really keen that this works. It's never easy to start something off. And I think because we've had prudent healthcare, we've had value-based healthcare, there's lots of different ways of saying the same thing. And I think in essence, Cardiff and Vale are really looking to push this forward and make it so once Drazen's done this and proved the data and the information that he's got at the end of the year, we'll be looking for that directorate to take that back as business as usual.
Yeah.
And so the first few projects, we're going to get things wrong. It's not going to be perfect. But I think that's really important to understand. It goes back to the directorate as business as usual, and we leave it as the value-based healthcare team. We leave it with them to move it on as they see fit, because we can't look after all the projects. But it is like an invite out there for all the clinicians. If you've got an idea, I will try and help you navigate. And I hope that's how Drazen feels, that I've helped him navigate through that as a new consultant, navigate the system and just, you know, use relationships and networks that we all have if we've been in the organisation for a while to get things moving forward.
So you mentioned that, you know, the clinicians can come to you. Is that the way that it works within your health board, or do you have a formal way of asking people for their ideas as well?
So I think what we're using is a lot of different ways of explaining to people that there is money out there. So that we've had a recent pull for projects. So there has been some money put aside in Cardiff and Vale for value-based healthcare projects. And at the moment, the steering group I know is looking at these projects at this very time. So they're looking at which projects they'd like to take forward. So there's been some money put aside, but also there should be projects still ongoing that don't need that upfront funding, that are actually just very sensible things to do clinically, either environmentally, and then generally the money falls out at the other end if it's sensible.
Yeah, and you were talking then about a really key process, about somewhere for people to go with really obvious ideas, but just need the support to wade through some of the treacle, if I diplomatically call it that, to get to the other side. Sometimes people don't know where to go. So as you said, you know, putting it out there that there is money, but also really keen, as you said, that it's not always money. Sometimes it is just the processes or the support to move that forward. And I really like the way that you said as well that it's important it goes back to the service as business as usual, because otherwise we get this apathy, don't we, of continuation of projects versus mainstream.
Yes.
Yeah.
Yeah, I think the other thing to add on to that is that once you've made this saving, you use that money or the theatre time saving in your directorate to do another value project. So that's what we're working through at the moment. I don't say we've got it right, but we are definitely working through that. How do you keep saving once you've started?
Yeah, and are there likely to be any challenges to that? Because sometimes it if something doesn't get used by someone else, it gets taken up by somebody else. So, you know, like beds and things, just because Drazen's patients aren't in those beds for those additional 5 days. Yeah, what do some of those conversations look like in being able to ring fence that for the department?
I think it's okay to let it go to other places and other things,
Yeah.
because we're such a stretched resource. It's okay actually, and if we can do it better, then that's fine. There may be medical patients that need those, or emergency surgical patients that need those beds, and we shouldn't use them if we don't need them. And I think it's okay to let it go to other resources. You know, that's what we should be doing. We should be all trying to save and help each other. It's a big team, really, to be a bit cliche.
No, but absolutely is, and it's that added value, isn't it? It's the knock on. If Dratton's saving beds and they can go to somebody else, and there's added value then for those waiting lists, those waiting times, and those elements there. So can you give us we've heard about Drazen's project. Could you give us some examples of some of the other projects you've been working on?
So because I was first appointed as Value Lead coming through the surgical board, that's where most of my project sits. So I have some other ones, but they're mainly there. So the very first project that we did was transnasal esophagoscopy project. So that was moving. So rather than patients following a massive pathway through the hospital, so they would have dysphagia generally, and that would then link through to a barium swallow, a theatre visit with an anaesthetic. Obviously, pre-assessment would precede that, and then they would have a pan endoscopy of some description. So all that pathway costs and is about, I think it was about 3 or 4 extra visits for the patients to the hospital, bearing in mind these patients, you know, have to park the car, etc., etc. There's all these other added benefits. They instead, in the outpatients, the surgeons are developing this at pace, actually. It's gone from 1 consultant to 3 or 4 now, doing the transnasal esophagoscopy in the outpatient clinics under local. So that will be a good example. That's gone back to business as usual. They've expanded from a single outpatient room to different rooms, and it's really flourished.
Fantastic. And has that been shared again across the clinical landscape with colleagues in other health boards?
I think they are nearly there.
Yep.
I think it's one of those things that you really want to prove that it's actually working well. They've started to expand, and I think once they've got it settled, they will.
Yeah. And it's that point, isn't it? When is it too early to share, when you're still learning the lessons and getting the outcomes, to the interest that's out there about people doing new things as well? And were there any other projects that you've been working on, Claire, or that you've supported recently across the health board?
There's some upcoming projects I've got. I was thinking, so there's other ones which are slightly different, which are, you know, trying to get workforce into outpatients. So, for example, pharmacists, trying to employ them into the pre-assessment service. What else have we got? I can't think of at the moment.
Put you on the spot.
Yeah, you have. I'm trying to think what other ones we've got. Bear with me.
No, so I'll leave that one with you.
Yeah.
So you were saying about the different ways that the clinicians can sort of come to with the projects. How does the steering group and the team decide what projects are value and which ones maybe just plugging a gap, if I put it that way? And I say that as a head of value-based healthcare because there is a difference, but sometimes they all come through in the ideas.
So I think if you work it through, so we've got a standard slide that we send out to people, which I can help people work through. I've done loads of those. I think if clinicians start working through that slide, and Drazen did that, so he did the first summary slide, then it will be value. If you've worked through it and you've come through the financial, you've worked with your financial business partner, you've worked through with your ops team, you've looked at the social benefits. If you've worked through that slide, you'll find out whether or not it is value for money.
Yeah. And is that something that you'd be willing to share with the people that are watching the podcast? It could be something we could send out, because I think that would be a really good tool for people when they're thinking, am I thinking value, or have I thought about everything when I'm thinking about value?
Yeah, and I think we're on version 2 or 3. I mean, it's not my slide. I can't lay claim to it. It's somebody in finance has designed it. But you know, I think we're updating it all the time, because there's areas where we can make it better. So we should. So yeah, we're on our updated version, and it's quite simple. It's quite easy to understand. I think if you bring Drazen in, I think he found it relatively easy to do. So yeah, I think it was good.
So go on then, Drazen. What was your experience of completing this slide and thinking about framing what you wanted to do through the lens of value?
Yeah, there were easy bits as well, but mine wasn't. It was a relatively easy project. So I had data from Glasgow, and it was easy to read through this. It was easy to read the slide, and it was easy to get out from the slide what we like to write down here and what's the outcome here. So like it was very easy even for me. So like though I'm not in management at all and I was not trained in management, but it was easy for a simple doctor like me as well to navigate through the slide, and it didn't take a lot of times. What took a lot of times is to connect to the other teams, and Claire helped me with that like we connected to the financial team and this and that, because what something costs X amount of money in Scotland, that doesn't cost the same amount of money in South Wales. So like, yeah, that was a little bit the time consuming bit, but apart from that, the slide itself was self-explanatory.
And I think you've both spoken about the need for that multidisciplinary support. So, you know, the activity, the expertise from the clinician. Claire, your support through, you know, through the landscape and linking out to those different teams, the finance teams. And on that side, have you then, you know, how do you measure the impact of the project along with finance and activity? Did you have any data quality issues, or, you know, was it quite straightforward for yourselves?
I think it was relatively straightforward. So on the slide, there's key performance indicators that we look at for each project. Keep them relatively simple and straightforward. But yeah, at the end of the year, we'll be expecting Drazen to give us his key performance indicators, and then we'll look at how much it's saved and whether it's actually done what it says on the tin. Because sometimes you have an idea and you think it's going to save money, but when you work it through, you might not start off as fast as you want to because of multiple different reasons. So you need to bear that in mind, I think, when you start your project, that actually maybe the first year is not going to be as good as you say it is, or you're not going to have the patient numbers, or there's going to be an equipment issue, or there'll be a footprint issue. So those are all the things that you need to work through and bear in mind when you're doing it. I think particular to Drazen's project, I think winning hearts and minds was a big thing for us. Especially, you know, it's just something new, and I think that's also something that needs to be worked through by lots of different people. Just, you know, do people understand why we're doing this is and why it's a good thing for patients?
Yeah, absolutely. And sometimes projects aren't always value in cost, but actually value in time, and it's about being able to work that back, because there are costs associated with those resources and assets as well, isn't there?
Yeah, I think, well, there's another project which I should have remembered, is a Green Theatre project, which is standardized by the Royal College of Surgeons. So they have a sort of a 12 to 15 point checklist, and it's all evidence-based, financially based, environmentally based. And we started that in Landock in Grey Theatre. It's been run primarily by the theatre sister, who has changed the way that we put the waste in the bins. There just aren't so many bins in theatre. She's looked at the instruments that the surgeons use, and she's checked off those 15 points on a regular basis for the last 3 or 4 months. And actually, we're becoming much more efficient in terms of what we use and throw away from an environmental perspective. So that Green Theatre is now starting to expand throughout the whole of Cardiff and Vale. And it's very easy to use because it's already out there from the Royal College of Surgeons. It's all evidence-based. You just need to follow their guidelines. So that's a really nice project that is environmentally based.
Yeah,
but the finance will fall out of that, because we're not washing instruments we don't use on a repeated basis.
Fantastic. Another really great opportunity there of something you said that's an easy win that's been put in place and been taken forward. So we've got another question from the audience, from Ravi Chana from Roche Diagnostics. So a question for Claire: would industry also be able to submit potential value-based healthcare projects through the same process, or is there a separate process?
There is no separate process because there's only one me. So yes, I don't see why not. There's definitely the opportunity that we need to work with industry. I mean, some industry partners give value vouchers and we work through those. So there's lots of different ways of working with industry. But so yes, definitely.
Well, there we go. Ravi, I think you'll be on the line to Claire then. So with regards to both of your areas of work, what does the future look like for you? So you've got a number of projects, you're looking to scale them to get the figures for them. But what would it look like next year or in 5 years with a value lens for Cardiff and Vale?
So from my perspective, what I'd like is to be able to be less hands-on each individual project, so be more of a facilitator, I think, and that just needs to grow through the organisation. So people need to have the ability to say, actually, that's the right thing to do. It doesn't necessarily have to have the value head mark on it, but we need to be able to just let things grow as they should. But yeah, that would be the goal for me, is to make sure that there's lots of projects that I don't personally need to be involved in, and just more of a, looking at it, do I need to help in that little area? Can I do anything to facilitate? Otherwise, if it's easy to do, let's just do it.
Love it. Love a JDI.
Yeah.
Drazen, and for you, one of the questions we've had in from Paul Williams at Powys is, are there other cancer specialties where this could be used? And you mentioned about the limitations, life cycle of the radioactive solution, but are there other areas that this could be rolled out to across cancer specialties?
I mean, I'm not, I'm only specialist in oral cancer,
I
but
know.
yeah, there are other specialties which are using already. So the breast is using it for decades. Gynecology, oncology is using it for probably a decade as well. So like there are other specialties which are using this already. I can see that this will happen, but again, we need to look at each specialty individually, whether this is scalable, whether this is doable there, and we need to probably run the pilot studies there as well. So we're not reinventing the wheel here. So this is something which has been in the ether for decades. We're just using it. So
yeah. Fantastic. So it sounds like you've got the bug a bit now, Drazen. It sounds like, Claire, you've got a bit of a champion here who's already thinking of other ways to scale and expand. I think I've answered all of the audience questions. I just want to thank you both for your time. I am sure that you're going to be getting emails, Drazen, about the project, and Claire about how people can submit projects from this. But thank you both very much for your time. Just to remind everybody, the next Healthcast now is the 20th of September, where it's Value in Surgery. And I'm sure David and Nick will be back for you then as well. But for now, don't forget, if you haven't been able to watch this or you want to share it with anybody else, it is available on the Wales Value in Health Team website. And I just want to thank you all and wish you all a very good weekend. So thank you very much. Thank you for your questions, and thank you both for your time and your great presentation then. Thank you.
thank you so much.
Thanks,
Bye-bye.
Dave. Bye.
Bye-bye.